Coming to thyroid, some basic physiology. Again, hypothalamus releases TRH. It acts on anterior pituitary to produce TSH. TSH acts on thyroid to secrete T3 and T4. What actually happens in the thyroid follicular cells is TSH acts on TSH receptor in the follicular cell. When TSH acts, one symporter, that is sodium iodide symporter, gets stimulated in the basolateral membrane. So what is this sodium iodide symporter? It takes in sodium and brings iodine into the follicular cell. So there is more iodine now. This iodine binds to a protein in the follicular cell called as thyroglobulin. This is called as iodination. So what happens? Something called as M8 is formed, monoiodotyrosine. Monoiodotyrosine joins with another monoiodotyrosine to form diiodotyrosine. Okay. So one monoiodotyrosine joins with another iodine to form diiodotyrosine. Now this DIT, when it joins with another thyroid, it forms T3. When it joins with another iodine, it forms T4, tetraiodothyronine. So this process is called as coupling, right? So just remember the names: intake, iodination, coupling. So what's the basic difference between T4 and T3 is, T4 is the abundant form. So T4 is the actual form which is present circulating in the blood. So T4 is the circulating form. T4 is the common drug which we replace, levothyroxine. Thyroxine is the drug which we commonly give for the hypothyroidism. But T3 is the active form. So nowadays T3 is also coming as a drug. So T4 is the major circulating form, but T3 is the active form. So T4 has a half-life of 7 days, but T3 has a very short half-life because it is biologically active. Okay, just remember this one. Now how will you interpret TFT? So this we would have discussed in many places. So this is the place where the concept of primary and secondary comes in play. So always while interpreting a TFT report, suppose in any case scenario or an exam, if some TFT is given, first step always see TSH. So assume if TSH is high, means only two possibilities. Either TSH is produced by anterior pituitary. So either the anterior pituitary is producing more TSH due to a hypersecreting disease in the pituitary, or anterior pituitary is secreting more due to a feedback. Right? That is what we understand. So if TSH is high, anterior pituitary is definitely producing more. It may produce more due to feedback from the thyroid gland, or it may be produced due to a disease. So how will you differentiate that is by seeing the T4. So if T4 is low, what does it indicate? If T4 is low, TSH is high, the thyroid gland is not producing any hormone. So TSH increases as a feedback. So it is primary hypothyroidism. Now what if T4 is normal but TSH is high? It is called a subclinical hypothyroidism. Now if TSH is high and T4 is also high, definitely it means TSH is high and TSH is high, so it is stimulating more of T4 production. So it is secondary hyperthyroidism. Right? You can understand the term now. Now what if TSH is decreased? If TSH is decreased, again two possibilities. If TSH is low, either it is low due to reduced production from the anterior pituitary due to hyposecreting disease in the anterior pituitary, or it is decreased because in periphery T4 is high and it is causing a feedback inhibition. It is decreased due to feedback inhibition. So how will you decide on that? By seeing the T4 level. So if TSH is decreased, T4 is high, it is primary hyperthyroidism. If T4 is low, TSH is low, and we'll see this one. If TSH is low but T4 is normal, it is called subclinical hyperthyroidism. It is still hyperthyroidism, but it is subclinical hyperthyroidism. When TSH is low and T4 is low, that it definitely means the pituitary itself is producing low. So it is called secondary hypothyroidism. Right? So what were the terms we discussed? One is primary hypothyroidism. So in primary hypothyroidism, T4 is low, TSH is high. What is secondary hypothyroidism? In secondary hypothyroidism, the problem is with the pituitary gland. Hypothyroidism is low T4. So T4 is low because TSH is low. Right? So this is why I was discussing about primary and secondary very early in this class, so that you will never get confused. So what is primary hyperthyroidism? Hyperthyroidism means T4 is high. Primary means the problem is with the gland. So TSH will be suppressed. Remember, this TSH suppression has to be around the 0.00 levels. Like if you say 0.5 to 5.5 is the normal range, 0.4 or 0.3 cannot be taken as suppressed. It should be 0.01 or 0.03 like that. Okay. Just for a practical tip. Now what happens in secondary hyperthyroidism? In hyperthyroidism, definitely T4 is high. What is meant by secondary? The problem is with the pituitary gland. So TSH is high. Now we also discussed two terms: subclinical hypothyroidism and subclinical hyperthyroidism. So what is hypothyroidism? In hypothyroidism, the classical definition is TSH has to be high, right? TSH has to be high. That's the classic definition of primary hypothyroidism. So subclinical hypothyroidism is nothing but primary hypothyroidism. Subclinical hyperthyroidism is also actually primary hyperthyroidism. Why it is called subclinical? T4 has not yet been low. So if TSH is high but T4 is normal, we call it as primary subclinical hypothyroidism. What is hyperthyroidism, subclinical hyperthyroidism? TSH is suppressed but T4 is normal. We call it as subclinical hyperthyroidism. Subclinical is also actually primary hypo or hyperthyroidism. Okay. If you are able to remember, please remember this also. I told you in secondary diseases, in secondary hypothyroidism, TSH will be low, T4 will be low. In secondary hyperthyroidism, TSH will be high, T4 will be high. But in some cases, TSH may be normal, T4 will be elevated in secondary hyperthyroidism. TSH will be normal, but T4 will be low in secondary hypothyroidism. Maybe this is actually a PG level discussion. I don't think they'll keep it for undergraduate examinations. But actually, low T4 or a low T3, a low T4 or a high T4 with a normal TSH is also secondary. Okay. So hypothyroidism, I think we'll be knowing the causes. There'll be puffy face, puffy hands, and the symptoms are very classic: dry skin, feeling of cold, hair loss, constipation, hoarse voice, menorrhagia. Remember, in hypothyroidism, bleeding will be excess. Now the opposite, hyperthyroidism. So what is hyperthyroidism? What is thyrotoxicosis? Practically, they are used together, but actually, hyperthyroidism is excess secretion. That is excess production from the thyroid gland. Thyrotoxicosis is production is normal, but excess release. For example, Graves' disease is a condition, or it is an autoimmune condition caused by TSH receptor antibody, TSH RAP. So TSH receptor antibody is an antibody. What it does is it binds to the TSH receptor. So I was showing you in the diagram, when TSH receptor binds, the intake of iodine, iodination, coupling, everything happens. So in Graves' disease, when TSH receptor antibody binds to the TSH receptor, it stimulates the entire process of thyroxine production. And T3, T4 becomes more. So Graves' disease is an stimulating autoimmune disease where TSH receptor antibody binds to TSH receptor and increases the production of T3 and T4. But assume another condition called as thyroiditis. Thyroiditis is, example, Hashimoto's thyroiditis. In Hashimoto's thyroiditis, there is lymphocytic infiltration of the thyroid gland. So there is destruction of the thyroid follicles. When thyroid follicles get destroyed, what happens? Whatever thyroxine is there within the gland will be released. So Graves' disease is called as hyperthyroidism because there is increased production of thyroxine. Whereas in thyroiditis, that is Hashimoto's thyroiditis, there is only a release of the preformed thyroid gland and there is no new formation. So it is called as thyrotoxicosis. It's just a small technical difference. So what are the other causes? Secondary causes are TSH secreting pituitary adenoma and struma ovary. It's an ovary which produces more thyroid. There can be excess iodine excess. For example, amiodarone is a drug which causes thyroiditis. Iodine causing hyperthyroidism is called Jod-Basedow phenomenon. Okay. So what is the most common cause of hypothyroidism? Previously it was thought to be iodine deficiency, but now autoimmune causes have taken the lead. So autoimmune thyroiditis. Graves' disease is also autoimmune, but in Graves' disease there is hyperthyroidism and the antibody is a TSH receptor antibody. Whereas in autoimmune thyroiditis, the antibody is TPO antibody. Hashimoto's thyroiditis is also autoimmune thyroiditis. In Hashimoto's, what happens is, initially I told you there is a release of thyroxine. So initially there is a thyrotoxic phase or a hyperthyroid phase. But over time what happens, due to permanent destruction of the thyroid follicles, later on they will become euthyroid and then they will become hypothyroid. So Hashimoto thyroiditis follows three phases. Initial thyrotoxic phase due to release of thyroxine from the thyroid follicles. Then they will become euthyroid, then they will become hypothyroid. So what are the signs and symptoms of thyrotoxicosis? Opposite to that of hypothyroidism. There can be diarrhea, there can be weight loss, and there is oligomenorrhea here. Please remember. The signs we know. Tachycardia, atrial fibrillation can occur, tremor, goiter. Diffuse goiter is a sign of Graves' disease. And there can be eye signs, lid retraction or lag. Lid retraction is the earliest eye sign of hyperthyroidism. You can see here, there is exophthalmos, lid retraction. What is lid retraction? We can see normally the upper eyelid covers a small portion of the cornea. But if you are able to see the entire cornea, it is lid retraction. So these changes are called thyroid acropathy. Hyperthyroidism can cause clubbing. Okay. So we just started a discussion about cortisol excess while discussing about anti-pituitary hormones. So we are discussing about the term ACTH dependent Cushing's and ACTH independent Cushing's. So ACTH dependent Cushing's is secondary, right? Problem is with the pituitary. ACTH independent Cushing's is primary. that is the problem is with the gland. Only the term has been given differently. Okay. So ACTH dependent Cushing's is secondary. That is problems with the pituitary gland. It was previously called Cushing's disease. So what are the causes? One, it's a pituitary adenoma. Now think of the next cause. It is a peculiar cause. ACTH can be produced from an ectopic source, especially cancer. Remember, at least small cell lung cancer. Remember, small cell lung cancer is a very important cancer because it produces many important paraneoplastic syndromes. One important paraneoplastic syndrome is Cushing's, ACTH dependent Cushing's. ACTH independent Cushing's is primary disorder of the adrenal gland, adrenal cortex. So what are the causes? Adenoma, carcinoma, hyperplasia, etc. Okay, so ACTH dependent two causes. ACTH producing pituitary adenoma or ectopic ACTH by tumors like small cell lung cancer. ACTH independent Cushing's is adrenocortical adenoma, carcinoma, hyperplasia. Before that, just a small thing about the physiology. I was telling you, ACTH controls only cortisol. But there are actually 4 hormones which are produced from the adrenal gland. So adrenal gland has 2 parts, that is adrenal cortex and adrenal medulla. Adrenal cortex has 3 parts, zona glomerulosa, zona fasciculata, zona reticularis. G, F, R. What does the G, glomerulosa, secrete? G does not go well with G. So glucocorticoid actually secretes mineralocorticoid. Mineralocorticoid is aldosterone. The F, fasciculata, goes with G. So fasciculata secretes the glucocorticoids. The important glucocorticoid is cortisol. Zona reticularis secretes adrenal androgens, testosterone and estrogen. So these are the 3 parts of cortex. Zona glomerulosa, which secretes mineralocorticoid aldosterone. Zona fasciculata, which secretes the glucocorticoid cortisol. Zona reticularis, which secretes androgen. Adrenal medulla is the inner part of the adrenal gland, which secretes epinephrine. Remember, norepinephrine, N for N. Norepinephrine is secreted by nerve endings, whereas epinephrine is secreted by the adrenal medulla. So, another thing about the control. I told you ACTH controls only the cortisol secretion. So, what does the mineralocorticoid is controlled by? The mineralocorticoid is controlled by the renin-angiotensin-aldosterone system, RAS system, or AAS. The second A stands for aldosterone, which is a mineralocorticoid. So, what is the stimulus for the RAS? It is any condition which depletes the intravascular volume. So when the circulating blood volume becomes low, when the renal perfusion pressure becomes low, the juxtaglomerular cells, the JG apparatus, JG cells get stimulated, it secretes renin. Kidney secretes renin. Function of renin is it converts angiotensinogen to angiotensin 1. So renin converts angiotensinogen to angiotensin 1. This angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, which is produced by the lung. Angiotensin 2 has 2 actions. One, by acting on the angiotensin 1 receptor, it causes vasoconstriction, and the other action is it stimulates aldosterone release from the adrenal medulla zona glomerulosa. Function of this aldosterone is to retain sodium and potassium excretion. Very important thing to remember. Aldosterone causes sodium retention and potassium excretion. And alkalosis. So aldosterone antagonists cause the opposite. They cause hyperkalemia and acidosis. Right? So function of aldosterone is sodium retention, potassium excretion, and causing metabolic alkalosis. So remember this. Renin converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 causes vasoconstriction and it stimulates aldosterone release. This pathway is very important pathway in renal failure, liver failure as well as in heart failure, because most of the drugs will act in this system. For example, one stimulus which makes kidney to secrete renin is sympathetic stimulation, beta stimulation. So we know the drug which inhibits sympathetic stimulation, beta blocker. So what inhibits angiotensin converting enzyme? All the prils, example enalapril, captopril. So angiotensin 2 acts on angiotensin 1 receptor. We have drugs against this, that they are called as angiotensin receptor blocker. All the sartans, irbesartan, candesartan, valsartan, telmisartan, olmesartan, and aldosterone. Aldosterone has some antagonists. They are called as mineralocorticoid receptor antagonist or aldosterone antagonist. There are two, eplerenone and spironolactone. So this entire pathway has a very important role in many drugs. So mineralocorticoid is not under the control of ACTH. ACTH controls mainly glucocorticoid and to a small part the adrenal androgens. Medulla is a totally different system. It's a part of the sympathetic nervous system. Okay. Likewise, the diseases vary. Deficiency of adrenal cortex is called adescence. Excess of adrenal cortex is called Cushing's disease. See, I told you the control is different. ACTH controls cortisol separately and mineralocorticoid is controlled separately. So excess has two diseases. Cushing's disease is actually cortisol excess. So there is a disease causing mineralocorticoid excess. It's called as Conn syndrome. Aldosterone secreting adenoma or aldosterone hyperplasia. So Conn syndrome is mineralocorticoid excess. Cushing syndrome is cortisol excess. Coming to deficiency, adescence is deficiency of any hormone. Adescence can be primary or secondary. Primary adescence is problem with the gland. So in primary adescence, both mineralocorticoid and glucocorticoid and sex steroids, everything will be affected. Right? Because primary is a problem with the gland, everything will be affected. Whereas in secondary adescence, that is, if there is a problem with the pituitary, ACTH or hypopituitarism, only glucocorticoid will be low. So mineralocorticoid will not be problematic, right? So which is more dramatic? Primary adescence is more dramatic because it has both mineralocorticoid and glucocorticoid deficiency, right? Cushing's we just now discussed. Instead of telling primary and secondary, we call it as ACTH dependent Cushing's and ACTH independent Cushing's. ACTH independent Cushing's is a problem with the adrenal cortex itself due to adrenal adenoma or adrenal hyperplasia. ACTH dependent Cushing's, it may be due to pituitary adenoma or it may be due to small cell lung cancer. So this is just a small summary of the entire system. Okay. So signs of Cushing syndrome we discussed already. I think we'll skip it. Buffalo hump, moon face, the typical purple striae. These are the skin bruises. Okay. So again a small discussion about the lab tests which are done. So what is Cushing's? Excess cortisol. So when do you say excess cortisol? Cortisol is high in times when it has to be low. So how will you screen it? By doing a midnight cortisol. Right? So I think we can discuss from this itself. So either a 24 hours urinary free cortisol is high Or I told you midnight salivary cortisol, because cortisol is normally low in the midnight. So if cortisol is high in the midnight, it means cortisol is definitely high. Now how will you confirm it? By doing a suppression test. We give exogenous steroid to suppress ACTH and to see what happens to the endogenous steroid level. So that is called as overnight dexamethasone suppression test, ONDST. An even better method to confirm Cushing's is doing a low dose dexamethasone suppression test. Overnight dexamethasone suppression test is a 1 dose of dexamethasone, 1 milligram. Low doses, dexa is given for 2 days in 0.5 milligram dexa. So when cortisol cannot be suppressed even with LD, low dose dexamethasone suppression test, it means we have confirmed the diagnosis of Cushing's syndrome. So now our aim is to find out whether it is ACTH dependent or ACTH independent. Right? How will you differentiate that? By seeing ACTH levels. Very simple. If you see ACTH, if ACTH is high, it is ACTH dependent Cushing's. If ACTH is normal, it is ACTH independent Cushing's. Now I told you ACTH dependent Cushing's, we had 2 reasons. Either it could be a pituitary adenoma or it is ectopic. So how will you differentiate? Obviously we can do a MRI of the brain. We can do a full body scan to look for things, but in the hormone wise evaluation, we can do high dose dexamethasone suppression test. High dose dexamethasone suppression test is we give 2 milligrams of dexamethasone every 6th hourly for 2 days. What is this test is? Pituitary adenoma can get suppressed with high dose dexamethasone, but ectopic secretion of ACTH cannot be suppressed by high dose dexamethasone. That is the most important thing. So if high dose dexamethasone suppression suppresses cortisol levels, then we have to evaluate for the pituitary. We have some special tests like pituitary transsphenoidal assessment. If it is ectopic, then we have to look for tumors elsewhere. Okay. If it is ACTH independent Cushing's, we have to look at the adrenals. That is what is the gist of this table. So this finishes Cushing's. And mineralocorticoid excess, I told you the disease is cons. Adrenal adenoma or adrenal hyperplasia. Adrenal adenoma or adrenal hyperplasia. What does it cause when aldosterone is high? BP will be high, right? Hypokalemia will be there. So high BP, hypokalemia, metabolic alkalosis. This is the syndrome which occurs in Conn syndrome. We have some rare syndromes also. For example, glucocorticoid remediable hyperaldosteronism. Like it's a crossover between some genes. Normally I told you ACTH does not control mineralocorticoid. If ACTH controls mineralocorticoid, then it is called glucocorticoid remediable hyperaldosteronism, which means it comes under the feedback of ACTH. If you give steroids, exogenous steroids, ACTH will get suppressed and mineralocorticoid also will get suppressed here. So in this syndrome, it's a rare syndrome, glucocorticoid remediable hyperaldosteronism. We have other syndromes like same, syndrome of apparent mineralocorticoid excess, Cushing's. That is when cortisol is very high, some of it overflows and acts like a mineralocorticoid. So if possible, you can discuss this. Remember Liddle syndrome also. Liddle syndrome, remember aldosterone, how does it act? Aldosterone acts on the kidney tubules to activate a channel called ENaC, epithelial sodium channels. This epithelial sodium channels in the collecting duct is responsible for sodium reabsorption. So till now we are discussing about diseases causing aldosterone excess. Adrenal adenoma, adrenal hyperplasia, same or GRA. In Liddle syndrome, there is a mutation in ENaC, activating mutation. Okay. So this is about mineralocorticoid excess. Addisons, I was telling you, there will be deficiency of cortisol, there will be deficiency of mineralocorticoid in primary adrenal insufficiency. So when cortisol is low, there will be fever. There will be low BP, partial hypotension, hypoglycemia, because I told you cortisol is one hormone which increases sugars. There will be hyponatremia because vasopressin has some relationship with cortisol. There are three receptors, right? V1, V2 and V3. V3 receptor has some connection with the ACTH system. When mineralocorticoid is deficient, again there will be hyponatremia, hyperkalemia, low BP, salt craving because of hyponatremia. And when androgen is deficient, lack of energy, lack of libido. Okay. So when Addison's can present with Addison's crisis, it's an emergency. So can you make out what clue is given here? There is hyperpigmentation, oral hyperpigmentation, nipple hyperpigmentation, hyperpigmentation of the hands. There can be facial hyperpigmentation. Why hyperpigmentation? In primary Addison's, what happens? Glucocorticoid, mineralocorticoid, sex steroids, everything becomes low. When cortisol becomes low, by feedback ACTH increases. One of the breakdown byproducts of ACTH is POMC, pro-opium melanocortin. Melanin gives black color to the skin. Okay. So, case scenarios can give this term. There is diffuse hyperpigmentation. It indirectly means it is primary Addison's. Secondary Addison's will not cause this. Remember, in Cushing's, ACTH dependent Cushing's also, there can be hyperpigmentation because ACTH is high, right? So hyperpigmentation means either it is primary Addison's or it is secondary Cushing syndrome. Okay. So another disorder of adrenal cortex is congenital adrenal hyperplasia. So this is one place where there is so much of confusion. Just remember, cholesterol through progesterone. Progesterone is the precursor for aldosterone production and cortisol production. So when there is a particular hormone, particular enzyme which is deficient, that is 21 alpha hydroxylase. When 21 alpha hydroxylase is deficient, aldosterone and cortisol is not formed. So what happens to the excess progesterone? It gets diverted to another pathway, that is excess progesterone get converted to 17-O-hydroxyprogesterone, and this gets converted to the formation of adrenal cortical steroids, adrenal cortical sex hormones. Okay, so I told you adrenal cortex produces three hormones: aldosterone, cortisol and sex steroids. So when 21 alpha hydroxylase is deficient, the entire progesterone gets converted to another pathway which is sex steroids. So when sex steroids become high, what will be there? For females there will be ambiguous genitalia, right, because of excess adrenal androgens. For males there will be precocious puberty. So, some gender issues plus there will be deficiency of aldosterone and deficiency of cortisol. So, their symptoms will be there. So, when it presents in pediatrics, there will be severe hypovolemia, hyperkalemia, hypotension. So, there are three common variants: 21 hydroxylase deficiency, 11 beta hydroxylase deficiency, 17 alpha hydroxylase deficiency. In all of these conditions, glucocorticoid is low. In all of these conditions, glucocorticoid is low. The additional finding is, just think of it as a mnemonic. Mineralocorticoid, sex steroid and glucocorticoid. Glucocorticoid is low everywhere. Think of the arrow. In 21 alpha hydroxylase deficiency, glucocorticoid is low, mineralocorticoid is low. sex steroids are high. In 11 beta hydroxylase deficiency, glucocorticoid is low, but mineralocorticoid is high, adrenal androgen is high. In 17 hydroxylase deficiency, glucocorticoid is low, mineralocorticoid is high, sex steroids are low. Right? Whenever there is one, you just put an up arrow and try to read it. Okay, so 21 alpha hydroxylase, maybe you can remember. There is low glucocorticoid, low mineralocorticoid, and increased sex steroid. So it causes hypotension, shock, renal failure, as well as failure to thrive in pediatrics, and there will be gender diagnosis issues. So these diseases are about adrenal cortical diseases. What is adrenal medullary disease? Pheochromocytoma. Right? Pheochromocytoma is a tumor of the adrenal medulla. It is one of the involvement of paragangliomas. So ganglions are also derivatives of the same embryonic precursor. So pheochromocytoma is one type of paraganglionoma. Usually they can occur together. So you know the typical, there will be sweating plus headaches and palpitation. At least remember these three. So how will you diagnose this? By metanephrines. Urine metanephrines, urine or plasma metanephrines. Okay. Just a few important things we'll discuss in very shortly. Till now we discussed about separate hormone excesses and separate hormone deficiencies. Suppose there are some conditions where hormone deficiencies occur together. That is due to autoimmune condition. So there are two of them. One is autoimmune polyendocrine syndrome type 1, autoimmune polyendocrine syndrome type 2. See here, Addison's, that is cortisol deficiency, hypoparathyroidism, hypogonadism, Graves' disease, type 1 DM. So all this is APS type 1. APS type 2 is Addison's, type 1 diabetes, Graves, and hypogonadism. Hypoparathyroidism does not occur here. Okay. So APS type 1 occurs early, APS 2 occurs late. So some questions may be asked here. Just remember there are some syndromes like this. Similarly, there is something called as MEN syndrome. We have MEN 1, MEN 2, MEN 4. So MEN 1 is multiple tumors. So there are parathyroid, pituitary, and pancreatic. So 3 P's you can think here. Pancreatic, pituitary, pheochromocytoma. Other tumors also can be there. MEN 1 is due to MEN 1 gene. MEN 2 we have MEN 2A, MEN 2B. Whenever you think of MEN 2, think of one important tumor which is medullary thyroid carcinoma, pheochroma, and parathyroid. At least remember MTC. MEN 2B is the same medullary thyroid cancer, plus they have some features like mucosal neuromas, morphonoid habitus, megacolon. So all M's, medullary thyroid, mucosal neuromas, morphonoid habitus, methylated corneal nerve fibers, and megacolon. Now we will discuss something about calcium. So calcium is mediated by 3 important hormones in the body. One is vitamin D, parathyroid hormone which is produced by the parathyroid glands, and calcitonin. The function of calcitonin is only calcium deposition. It does not play a major role, but the other two are very, very important. So we know vitamin D, by the exposure of sunlight, the vitamin D precursors come. The liver, by the enzyme 25-hydroxylase, converts vitamin D to 25-hydroxy vitamin D. The 25-hydroxy vitamin D is converted by the liver 1-alpha hydroxylase to 1,25-dihydroxy vitamin D3. Okay, so the kidney has 1-alpha hydroxylase liver has 25 alpha hydroxylase. So finally we get 1,25 dihydroxy vitamin D3. This is the active form of vitamin D3. What does vitamin D3 do? It causes calcium absorption from intestine. This is the major function of vitamin D. Now think of parathyroid hormone. Parathyroid hormone is produced by the parathyroid gland. It has three important functions. The main function of parathyroid hormone is to increase calcium in blood. How all can it increase calcium? One, it increases calcium release from bones. It causes calcium resorption from bones. Second, it increases calcium absorption from the GIT. This action is brought about by vitamin D. Through vitamin D, PTH causes increased calcium absorption from the GIT. And what happens in kidney? It causes calcium reabsorption from the proximal tubules. We also have some action on the phosphate. PTH reduces phosphate level. So the function of PTH on phosphate is absent. So it causes phosphate excretion through the distal tubules. So there is phosphate excretion through the distal convoluted tubules. Calcium absorption is by the proximal convoluted tubule. So the stimulus for PTH is high phosphate or low calcium. So high phosphate or low calcium, these two triggers increase PTH. So PTH increases calcium by increasing calcium resorption of the bones, increase calcium absorption from the GIT through vitamin D, and increase calcium reabsorption from the kidney. So the function of PTH is to increase calcium. So we'll discuss about hypercalcemia. The most important two causes of hypercalcemia is hyperparathyroidism. Second one is malignancy, paraneoplastic. So we just discussed parathyroid adenoma is a part of Men's syndrome. So there are only two causes of hypercalcemia. If you have to remember two, one is hyperparathyroidism. We just discussed how hyperparathyroidism causes hypercalcemia. The second one is malignancy. Malignancy causes hypercalcemia by many reasons. One, malignancy can produce PTH related peptide. That is, PTH levels will be normal, but malignancy produces another substance called as PTH related peptide, which acts like the same way as parathyroid hormone to increase calcium reabsorption. One important place where this occurs is squamous cell carcinoma of the lung. Remember, small cell carcinoma of the lung is very important because most of the paraneoplastic manifestations are due to small cell carcinoma of the lung, except hypercalcemia, which is caused by squamous cell carcinoma of the lung. How does it cause? By parathyroid hormone related peptide. There are other ways by which malignancy causes hypercalcemia. One is by bone metastasis. We have bone lytic mets and we have bone depositing osteoblastic mets. Remember the word lytic. Lung tumors, ureteric tumors, testicular tumors, intestinal tumors, colonic tumors, all these cause osteolytic mets. So these are the main lytic mets. Prostate is an osteoblastic met. Remember, P and B usually come together. Breast is blastic and lytic. It is mixed. Okay, so these meds also can cause. So only two causes of hypercalcemia which you must remember. One is hyperparathyroidism, another one is malignancy. Of course, there are other causes, for example, granulomatous diseases, hyperthyroidism, etc. So how will you treat hypercalcemia? Hypercalcemia is an emergency. So the normal calcium level is 9 to 11 milligrams per deciliter. When the levels cross more than 13 milligrams per deciliter, it's a life-threatening emergency. Usually it causes the moan pain disease. So it causes irritability, constipation, it causes dehydration. So this is usually treated in the ICU. The first thing is hydration. Next is you can give diuresis, that is saline plus furosemide. Furosemide causes calcium excretion. Then we can give bisphosphonates. Bisphosphonates are drugs which cause deposition of calcium in the bone. Pamidronate, zoledronic acid, denosumab. Denosumab is a monoclonal antibody. Then we have other drugs, calcitonin. I already discussed calcitonin is a drug substance which deposits calcium in the bone. So steroids can be given. In the last stage, dialysis is done. Okay, hypocalcemia, the common cause is vitamin D deficiency. Hypoparathyroidism can cause hypocalcemia. Remember, we are not discussing pediatrics, we are discussing only adults. So CKD is a cause of hypocalcemia. Vitamin D dependent rickets, reduced dietary intake, and other conditions like tumor lysis, aka rhabdomyolysis. So whenever tumor lysis or rhabdomyolysis occurs, all the phosphate from within the cells get released. So when phosphate is more, we know that PTH is secreted more. But the excess phosphate itself will bind to the calcium and form calcium phosphate. So calcium will become very low in these conditions. So despite high parathyroid, calcium will be low in these conditions. So that is why in CKD, phosphate is not excreted. So phosphate levels will be high in the blood. The main trigger for parathyroid secretion is high phosphate. So phosphate increases here. So when phosphate is high, PTH is high. This PTH increases calcium. So this is called as secondary hyperparathyroidism. So we know about the primary hyperparathyroidism, parathyroid hyperplasia or parathyroid adenoma. So this secondary hyperparathyroidism is in CKD, there is increased PTH secretion. This is secondary hyperparathyroidism. So when PTH is more, what does it do? It causes erosion of the bones. So that condition is called as osteitis fibrosa cystica or von Recklinghausen tumors or the brown tumors, however we call it. Now what happens when secondary hyperparathyroidism lasts for a longer time? Some of the parathyroid tissue starts to secrete PTH on its own. So that is called as tertiary hyperparathyroidism. Remember we discussed about primary, secondary in endocrine diseases. Primary is the problem with the gland itself. Secondary is a problem with the pituitary. There is some discussion that there is a disease called tertiary diseases, like tertiary hyperparathyroidism is a problem with the hypothalamus. But in calcium homeostasis, that is different. Primary hyperparathyroidism is primary secretion from the gland. Okay. Secondary hyperparathyroidism is high parathyroid due to CKD. Tertiary hyperparathyroidism is increased PTH secretion from a hyperplastic parathyroid. Okay. So this finishes the endocrine. I will just quickly go through some metabolic diseases, diabetes. We'll start with obesity. So just exam point of view, there are some syndromes which can cause obesity. For example, Prader-Willi syndrome, Albright's hereditary osteodystrophy, Bardet-Biedl syndrome, Carpenter syndrome, Cohen syndrome, Alström-Stubbe syndrome. These are some syndromes which cause obesity. So this is the simplest version of obesity pathogenesis. We have many hormones like ghrelin. Ghrelin can be split like this, GH-ghrelin. So ghrelin is a substance which releases GH. When GH is more, growth is more, right? So GH increases obesity. Ghrelin increases obesity. We discussed about, so ghrelin is one thing which increases weight. We have leptin. Lepto means something which is lean. So leptin is a substance which is secreted by the stomach which increases satiety and reduces weight. And satiety increases, weight reduces. I think what is important in the current trend is GLP-1, because we have important drugs called as GLP-1 analogs. So what is this GLP actually? GLP or GIP, these are insulin secretagogues. What are these insulin secretagogues? So when we take food, they break down and some peptides are formed. Food breakdowns into some peptides. These peptides in turn stimulate these hormones, GLP and GIP. So these are some of the intestinal hormones, paracrine hormones which are produced. This GLP-1 and GIP-1, they secrete insulin. So this process is called as food-dependent insulin secretion. That is, there is insulin secretion only when food is there. One of the pathogenic mechanisms of diabetes is incretin deficiency, right? So these are called as incretins. So these two are called as incretins. So when this incretin is deficient, there will not be food-dependent insulin secretion. So insulin deficiency leads to diabetes. This is one of the pathogenic mechanisms in diabetes. So incretin deficiency or GLP-GIP-1 deficiency. So if you are giving agonist of this, what happens? Diabetes will reverse because insulin starts to get secreted. Another important function of this GLP-1 and GIP-1 is to cause satiety. Okay, so the GLP-1 analogs, which is now trending, is semaglutide. Previously we had liraglutide. So these drugs can be used for two purposes. One, they are used for diabetes because it is an incretin. And liraglutide, and they can also be used for obesity because it causes satiety, right? Apart from satiety, this GLP and GIP also have some mechanisms on fat metabolism also. There's another drug called as tirzepatide, which acts on both GLP-1 and GIP. So it is called as twin cretin agonist. Okay, so semaglutide and liraglutide are GLP-1 agonists, GLP-1 analogs, which are used in DM and obesity. Tirzepatide is an even better version because it acts on both GLP-1 and GIP-1. So it is also used in DM and obesity. It can also be used for obesity-related diseases like OSA, etc. So that's why you must remember this ghrelin, GH1, etc. So diabetes, we know the definition. So the diabetes is said to occur when fasting glucose is 126 milligrams per deciliter or more, 2 hours postprandial glucose is 200 or more, or HbA1c is 6.5 or more. What is pre-diabetes? HbA1c is 5.7 to 6.4. Fasting post glucose is 100 to 125. and 2 hours postprandial is 140 to 199. We usually say pre-diabetes in two terms: impaired fasting glucose and impaired glucose tolerance. If the fasting glucose is between 100 to 125 and postprandial glucose is less than 140, we say it is impaired fasting glucose. Only fasting is problematic. Impaired glucose is both fasting glucose is between 100 to 125 and postprandial glucose is between 140 to 200. When PPG crosses 200 or FPG crosses 125, it is called diabetes. Now the classification of diabetes says 4 major categories. Type 1 is complete deficiency of insulin. Type 2 is insulin resistance. Type 3 we have many categories. So at least remember type 3A is MODY, maturity onset diabetes of young. So if we have to remember the basic of MODY, it is actually maturity onset diabetes of the young. That is, it is a type 2 diabetes like pathology which occurs in the young. Because type 1 diabetes is autoimmune disease which causes absolute insulin deficiency. Usually type 1 insulin diabetes is common in young. This type 2 diabetes is insulin resistance which occurs in elderly usually. This MODY is a type 2 like diabetes which occurs in the young. So what are the other differences between type 1 and type 2? When there is absolute insulin deficiency, type 1 diabetes needs insulin. It has very poor response to oral hypoglycemic drugs. And the chance of diabetic ketoacidosis is more because of absolute insulin deficiency. Insulin resistance does not have these features. But MODY is a young age diabetes only, but it presents like a type 2 diabetes. That is, it responds to OHS. That is why if any scenario or if you see an actual patient who is a 10-year or 12-year-old who comes with diabetes, we need not start them entirely on insulin, considering that it is type 1 diabetes, because it could be MODY also. So we have to evaluate. We have a MODY panel. We can look for all these genetics. So MODY type 1 is HNF4 alpha, MODY 3 is HNF1 alpha, MODY 4. So there are many types. So if one of these genes is positive, they will respond to OHS. You need not give them insulin. That is why we must know MODY. Type 3C is pancreatitis associated diabetes. Type 3E is endocrinopathy associated. And type F is drugs associated, like steroid associated, etc. Okay, so type 4 is gestational diabetes mellitus. So these are some types of diabetes which you must remember. So about the drugs, we know metformin is a biguanide. It decreases hepatic glucose production. That is its main mechanism. Alpha glucosidase inhibitors inhibit glucose absorption from the gut. So acarbose, oglibose are the two important drugs. Now what about dipeptidyl peptidase inhibitors? We discussed about GLP-1 analogs. Dipeptidyl peptidases are proteins which break down GLP-1. So when we inhibit dipeptidyl peptidase, GLP-1 will increase, right? So incretin will increase. So that's what dipeptidyl peptidase inhibitors are. So our famous gliptins, vildagliptin, sitagliptin, linagliptin are dipeptidyl peptidase inhibitors which inhibit dipeptidyl peptidase. Hence they inhibit the destruction of GLP-1 and it increases GLP-1. Sulfonylureas are insulin secretagogues. We have another insulin secretagogues apart from sulfonylureas, which are glinides, repaglinide, natiglinide, etc. Remember SGLT2 inhibitors because these are anti-diabetic drugs which are used in heart failure. So what is SGLT? Sodium glucose cotransporter 2. We have another transporter which is SGLT1, sodium glucose cotransporter 1. SGLT1 is present in the intestine. SGLT2 is present in the kidney proximal tubule. The function of this co-transporter is to absorb sodium and glucose together into the blood. SGLT1 absorbs the same sodium and glucose into the gut and into the blood. So when sodium and glucose reabsorption from the kidney is inhibited by SGLT2 inhibitor, what will happen? Excess glucose comes in the urine. So this predisposes to UTI. So if a scenario is given, patient is taking an anti-diabetic drug, there is a chance of UTI. Which group of drugs causes? SGLT2 inhibitors. Anything which ends in glyphosine, dapagliflozin, empagliflozin, canagliflozin. So these are the drugs which are SGLT2 inhibitors. Thiazolidinediones, they are the pure insulin resistance treating drugs. So these thiazolidinediones are pioglitazone and rosiglitazone. They are PPAR alpha agonists. Remember, there is a drug called PPAR gamma agonist. They are phenofibrates. The fibrates, phenofibrate are PPAR gamma agonists, which are used in dyslipidemia. The PPAR alpha agonist is pioglitazone, which is used in diabetes. We have combined PPAR alpha and gamma agonist. PPAR is peroxisome proliferator activated receptor. It is something which acts at the cellular level. PPAR alpha plus gamma agonist is saroglitazar. It can be used in diabetes, it can be used in dyslipidemia. Usually, commonly it is used in fatty liver. Okay. So biguanide, metformin, sulfonylureas are the glycoside glimepiride group, which increases insulin secretion. Alpha glucosidase inhibitor inhibits glucose reabsorption. Dipeptidyl peptidase inhibitors increase the level of incretins. SGLT2 inhibitor prevents sodium and glucose reabsorption. Thiazolidinediones, PPAR alpha agonist, which reduce insulin resistance. And GLP-1 receptor agonists we just discussed, semaglutide, liraglutide, tirzepatide. They are the famous drugs now. So this is about diabetes. So what are the diabetic emergencies? There are 3 diabetic emergencies. One is diabetic ketoacidosis, HHS, hyperglycemic hyperketotic state. The third is hypoglycemia. So DKA we just discussed. It's common in type 1 diabetes. There is absolute insulin deficiency. In HHS, there is no absolute insulin deficiency. That is, some insulin remains. So why this small pathophysiological difference is important is when there is absolute insulin deficiency, the lipids get broken to form more fatty acids and ketones get formed. That is why diabetic ketoacidosis. In DKA, ketones are formed. Ketones are more dangerous because they cause acidosis. They cause very severe fluid loss and dehydration. In HHS, these ketones are not formed. Only hyperglycemia is the problem. So how will you treat DKA and HHS? It is only by fluids. If someone asks which is the most important treatment in DKA or HHS, it is invariably fluids. It's not insulin, it is fluids. Because dehydration is the cause of death here. After fluids, it is the electrolyte correction. Because most of the time, dehydration leads to hypokalemia. Hypokalemia can lead to death. So always correct potassium before giving insulin. Some questions may come on DKA. So diabetic ketoacidosis, these are the 3 components. There should be diabetes, there should be ketosis, there should be acidosis. When do you say sugar is high? When it is more than 250 milligrams per deciliter. When do you say ketosis? When ketone body is more than 3 milligrams per deciliter. When do you say acidosis? When bicarbonate level in the blood is less than 18 milligrams per deciliter, 18 milliequivalents per liter. Okay, just a definition. How will you treat? Fluids is the main choice, and usually decay is triggered by some emergencies like fever, any infection, MI. So in these conditions we should watch for decay. So hypoglycemia, usually diabetic patients who are taking insulin or insulin secretagogues like sulfonylureas get hypoglycemia. There is a disease called as insulinoma. Insulinoma is an insulin secreting tumor which is produced by the pancreas. So when insulin is high, what happens? There will be hypoglycemia. And usually people say about Whipple's triad. So when do you say Whipple's triad? Hypoglycemia. One patient has symptoms of hypoglycemia. We can divide hypoglycemic symptoms into two categories. One is autonomic or sympathetic symptoms like the irritability, sweating, palpitation, tachycardia. All these are the sympathetic symptoms. They come earlier. Next comes the neuroglycopenic symptoms. Neuroglycopenia is the drowsiness, coma, fatigue and coma which occurs, right? So sympathetic symptoms occur earlier, then comes neuroglycopenic symptoms. In patients taking beta blockers, sympathetic activity is blocked, so they directly go for neuroglycopenic symptoms. So beta blocker should never be given in people who are at risk of hypoglycemia. So what is the actual level of hypoglycemia? Less than 70 milligrams per deciliter is hypoglycemia. So you must know the diabetic cutoff, you must know the DKA cutoff, you must know the hypoglycemia cutoff. So one is patient has symptoms of hypoglycemia, then there should be documented hypoglycemia. That is the level which I told you. Third, there should be reversal of symptoms with sugar administration. Only if these three is there, they say it as Whipple's triad. Sugar or glucose administration. This is just for discussion's sake. Whipple's triad, insulinoma. Okay. So now we will finish the last two sections. What is dyslipidemia? We have something called as familial dyslipidemia. There are 5 types. Type 1, type 2A, 2B, 3, 4 and 5. Type 1 is called as familial hyperchylomicronemia. Chylomicron are the dietary triglycerides. The triglycerides which come from the diet are called as chylomicrons. So predominance of chylomicrons is type 1. Type 2 is familial hypercholesterolemia. It is shortly called as FH. So it is a problem with the LDL receptor. So usually LDL receptor is present in the liver. The function of LDL receptor is to catch LDL from the blood and to bring it to the store it in the liver. So the blood will have less of LDL. So when LDL receptors are problematic, the liver cannot internalize LDL. So patients will have high level of LDL. So what is the clinical syndrome here is they will have tendon xanthomas. So type 3 is called familial dysbeta lipoproteinemia. Here there is something called intermediate density lipoprotein. Here we get something called as Palmar erythema, Palmar xanthomas. We had discussed it in one separate question discussion. And type 4 is called increased VLDL. It's called familial hyperlipidemia. Type 5 is familial mixed hypertriglyceridemia. So here we can get eruptive xanthomas. So when triglycerides are high, there will be eruptive xanthomas. In type 3, there will be Palmer xanthomas. Type 2 is familial hypercholesterolemia. It is increased LDL. So in usually familial hypercholesterolemia, LDL will be very high. It will be more than 190 milligrams per deciliter usually. Okay. Now metabolic syndrome. Some questions or scenarios may come on the criteria. Just remember there is central obesity. So for South Asians, men have more than 90 centimeters. Females should have more than 80 centimeters to say it as central obesity. Hypertriglyceridemia. LDL is not a part of metabolic syndrome diagnosis. Triglyceride more than 150 and low LDL less than 40 is only hypertriglyceridemia. Okay. And hypertension, that is blood pressure more than 130 or diastolic blood pressure more than 85. And fasting plasma glucose more than 100 itself is a diagnosis of metabolic syndrome. And or he should be taking drugs. So of these things there should be 3. Nothing but it's diabetes, hypertension and dyslipidemia and obesity. So how will you define obesity here? By the waist circumference, more than 90 centimeter in males and more than 80 centimeter in females. DM by the use of drugs or fasting plasma glucose should be more than 100. Hypertension more than 130/85. Dyslipidemia is by low HDL or high triglyceride. Okay. So we started off with some basics in endocrine and we discussed about the hormone excesses, hormone deficiencies, how will you test and how will you analyze the symptoms, right? And we went about diabetes, obesity, metabolic syndrome also. Thank you.